Good afternoon, everyone. I welcome you all to the 52nd Cuddles online neonatology talk today. I'm delighted to announce that it's been 1 year since we embarked on the journey of this series of webinars for neonatologists and practicing pediatricians. And I feel very fortunate to be a part of it all through these days. I would like to express my heartfelt gratitude to our esteemed KIMS management, Dr. Bhaskar sir and Abhinay sir, for their continued support and encouragement. The Cuddles online neonatology education is the brainchild of our HOD and mentor, Dr. Aparna ma'am, whose creativity, innovation, and passion in neonatology has been instrumental in the formation of a diverse range of topics, integrating both theoretical as well as beneficial practical aspects. I would like to extend my thanks to all the dignified consultants in neonatology and other allied specialties for collaborating with us and sharing their valuable knowledge on this platform through the form of lectures and practical live demonstrations. I would also like to thank our fellows and DNB students whose curiosity to learn kept us motivated and challenged us to improve ourselves every week with new series of talks. Our nurses have been the constant pillar of support who practically implement the knowledge that we try to share every day in the NICUs. A big shout out to our marketing team and branding and communications team for helping to circulate these talks on the social media platform for those who are interested to see them. Last but not the least, I would like to thank our operations and IT team for supporting us with their constant efforts. With all your unwavering support, we will be coming up with new series of topics and interesting topics from the next week onwards, which we will be announcing shortly. So keep subscribed to our channel and keep following our videos for more useful and practical information in neonatology. Without much ado, I will like to begin today's topic, which is the growth charts and extrauterine growth restriction in preterm neonates. So let's begin the topic. I would like to begin this topic with a case scenario. Slides. Okay. So this is a hypothetical case of an extreme preterm 26-weeker baby who was born as appropriate for gestational age according to the Fenton's growth chart with a birth weight of 780 grams. Antenatal steroids, 2 doses were given to the mother in view of preterm labor before delivery, but the last dose was given just 12 hours prior to the delivery. So that was considered as an incomplete antenatal steroid course. Baby cried immediately after birth, but had severe respiratory distress, and the baby had to be intubated. And the baby had respiratory distress syndrome changes on chest X-ray, and in view of high FiO2 requirement, the baby needed 2 doses of surfactant. So the baby initially was resuscitated and managed according to our golden hour management, and the baby's admission temperature was normal, and the baby was started on incubator care with 85% humidity. So after 2 days, the baby could be extubated to non-invasive mechanical ventilation. The initially total volume of 60 ml per kg per day of TPN was started on the day 1 of life itself. Then by the time the baby's weight could be checked on the 3rd day after extubation, the baby showed a 10% weight loss, which is approximately a weight of 700 grams for the baby. Because Doppler changes, the feeds were initiated with minimal enteral nutrition at 6 hours of life, and the feeds were slowly hiked up according to the protocol. On day 5 of life, the baby was noted to have feed intolerance in the form of abdominal distension and some aspirates of the feed volume. So the baby was kept nil per oral. So I'm just telling the case history of this baby. You can keep thinking like what went wrong at each stage so that we will discuss this also later. So then after nil per oral, the baby was kept MPO for 2 days, and then again feeds were restarted on day 7. So the feeds were being continued. On day 10 of life, the baby was noted to have mottled with prolonged CFT of 4 seconds and poor pulse volume. So at this stage of life, the baby was diagnosed as having the late onset sepsis, for which baby needed ventilation again and inotropes and IV antibiotics. Subsequently, this baby continued to have recurrent extubation failures due to lung collapse and consolidation, needing prolonged NIMV support, and finally ended up having BPD changes in the lungs, for which the baby was given dexamethasone as per DART regimen before the discharge. And by day 14 of life, this baby's weight was around 17% below the birth weight. So at this stage, the baby was noted to have diarrhea also. So the feeds were changed and the baby was kept on elemental formula, and fortification had to be stopped. The baby subsequently had anemia and hyponatremia, which were corrected, which also contributed to the weight loss. So due to this prolonged feed intolerance, the baby had to be kept on prolonged total parenteral nutrition and elemental formula. Later on, during the subsequent monitoring, the baby developed cholestatic jaundice, which was thought to be related to the TPN. And CMV infection was also ruled out. CMV came positive and the baby had to be treated with ganciclovir. So the baby was discharged at the age of 3 months from the time of admission with a weight of 1500 grams. Now, I will show you the growth chart of this baby. This was the Fenton's chart. So if you can see, at the time of birth, the baby's weight was at the 50th centiles. Then the baby slowly started losing the weight. And by 1 month of age, you can still see that the baby is below the birth weight. The baby slowly regains the birth weight. And by 8 weeks, that is 2 months of age, the baby reaches the birth weight. And at the time of discharge, the baby is way below the 3rd centile as per the intrauterine growth charts, and continues to lag in the growth even during the further follow-ups. If we can observe from this chart, the head circumference and length are also below the 3rd centiles. So we were able to successfully discharge the baby, but do you think that growth-wise, did the baby fare well in the NICU? No. This is because of so many morbidities and complications the baby faced during the NICU stay. This is known as EUGR. In today's webinar, we will learn how to prevent this EUGR. I will show you the second case. This was a 29-weeker born as a small for gestational age EUGR baby with a weight of 540 grams. This was one of the twin gestation. This baby had severe growth restriction with absent end diastolic flow on the scans, and the baby was delivered by LSCS. Baby was an outborn and was kept in an outside NICU where they did not have any incubators or were not able to administer any TPN, and was transferred at day of life 5. This baby also required prolonged respiratory support, subsequently developed feed intolerance. HMF and MMF had to be stopped, and the baby had to be kept on elemental formula, and had other complications like sepsis, morbidities like ROP, which was treated, had bronchopulmonary dysplasia, and grade 2 to 3 IVH, which was also managed conservatively. This baby also ended up having growth faltering and EUGR. So this was the growth chart of this baby, where you can see that the discharge weight was below 3rd centiles and all the anthropometric parameters are well below the 3rd centiles. So this is a case 3. Here we can see a very preterm 28 plus 4 weeks, antenatal steroids completely covered baby, delivered prematurely in view of preterm premature rupture of membranes. The baby was never intubated, cried immediately after birth, had good upguards, and was started on delivery room CPAP. 1 dose of surfactant was given by Insure technique due to the oxygen requirement and X-ray suggestive of RDS. Subsequently, this baby never had any complications in the form of hemodynamically significant PDA or culture positive sepsis or IVH. So the baby was brought to room air by 10 days of life by gradual weaning of the CPAP. Feeds were started on the day 1 of life, and the baby tolerated feeds, and we could escalate the feeds as per the protocol. And baby reached full orogastric feeds by 1 week of life. Total parenteral nutrition was stopped by 6 days of life. Early KMC could be initiated for this baby. Mother fortunately could give her own milk for the baby. The baby was on complete mother's own milk and tolerated the feeds well. And this baby was discharged earlier. baby had anthropometric parameters by the time of discharge. 14 days itself, the baby came to the birth weight, and the anthropometric parameters, the baby grew normally. And by the 40 weeks and 44 weeks, all the parameters were within the normal range, that is above the 10th centiles. So you can see the subsequent follow-up of the baby according to the WHO MGRS charts modified by the IAP. So if you can see by 1 year of life, this baby could catch up to the third centiles, and by 15 months of life, the baby was in the normal range according to this WHO charts designed for the term infants. So if we see the difference between the first two cases and the third case, because of so many factors, the first two babies could not achieve the appropriate growth, which is advised by the American Academy of Pediatrics for the babies. They both had the growth faltering, but the third baby was able to achieve good growth. So now let us see what are the factors that influence the fetal growth. The fetus experiences an exponential growth of six-fold between 22 to 40 weeks of gestation intrauterine, and the fetal growth will be affected by several factors like fetal factors, placental factors, and maternal factors. Twin gestation, Doppler abnormalities, and placental abnormalities, maternal age, height, parity, and maternal risk factors like gestational diabetes, pregnancy-induced hypertension, and her anemia, and thyroid status, and nutritional intake during pregnancy. All these factors affect the baby's growth, and poly and oligohydramnios. All these factors affect the baby's growth, and there will be a fetal growth, which will be according to the genetic potential also. So why does a growth faltering occurs once the baby is born? Once the baby is born, the same intrauterine growth may not be achievable in most of the babies, and they end up faltering in the growth due to these common factors like inadequate feeds, stopping feeds at the slightest doubt of any feed intolerance, hiking up feeds very slowly, any chronic illnesses like bronchopulmonary dysplasia, chronic infections, torch group of infections, and bacterial infections, meningitis, hypothermia at birth, and not maintaining the humidity and body temperature also leads to growth faltering, and metabolic conditions like hyponatremia, anemia. These are all the common factors which lead to the growth faltering in the neonate. So now we should understand why the preterms are at risk of growth faltering. They are born like at the end of the second trimester or in the beginning of the third trimester, where if the baby has been intrauterine, the baby has the potential to achieve a rapid growth. So when the baby is born with a limited nutritional reserve of 200 to 400 kilocalories, and the baby's metabolic pathways will be immature, and will have increased nutrient demands due to insensible losses of water from the skin, and sickness of the premature baby, increased respiratory distress, ventilatory support, and increased catabolism, and more risk of medical and surgical problems like NEC, IVH. All these problems leads to growth faltering in a preterm neonate. Compared to the intrauterine growth, the postnatal growth will be attributable to all these different factors, which contribute significantly to the weight gain of the baby. So now we should know why is monitoring important in such babies. There have been numerous studies which show that poor in-hospital growth affects the neurodevelopmental outcome in the long term of a baby. Higher linear growth, weight, and head circumference are associated with better neurodevelopmental outcomes. So that's why we should put our every effort to achieve intrauterine growth rates for the babies to give them a better neurodevelopmental outcome. And poor growth is associated with increased incidence of ROP, and metabolic syndrome is common in EUGR babies in the long run if they are at a risk of being overfed in the follow-ups. So how does good monitoring help? Good monitoring by the form of growth charts helps to compare the baby's growth with the standard growth. For that, we should know what is the standard. We will come to that, and early identification of the babies who are faltering and at risk, and interventions that need to be taken at that particular stage. Good monitoring and good in-hospital growth decreases the incidence of cerebral palsy in the later stages. So now let us see the importance of nutrition and growth monitoring. So in this study by Aaron Kranz in the Pediatrics 2006 article, 600 babies were studied who were born with a weights between 501 to 1000 grams and were evaluated at 18 to 22 months of gestational age. So if there is a better weight gain, increased weight and head circumference that was related to the decreased incidence of cerebral palsy and good mental developmental index, decreased chances for abnormal neurological examination or neurodevelopmental impairment, and there was also a decrease in need for rehospitalization. So now we know the importance of growth monitoring in any preterm baby admitted to the NICU. So how do we do that? We do that in the form of growth charts. There are two different types of growth charts. The first one is the growth reference chart and the second one is the growth standard chart. What is a growth reference chart? The growth reference chart will tell us exactly the anthropometry of a baby without taking the baby's health status into consideration. These are only descriptive type of charts in which they will tell us what is the growth of the baby, how it is, but not exactly how it should be. Standard charts are the charts which are selected on the basis of the health status of the baby. These are prescriptive charts, means that they tell us like how the baby's ideal growth should be. So descriptive charts just describe the growth of a baby without prescribing any standard. Standard charts are prescriptive in that they tell us how the ideal growth of the baby should be. Now let us see in detail these two different types of charts. Descriptive charts, there are three types of charts: intrauterine charts, postnatal and fetal infant growth charts. In the intrauterine chart, the anthropometric parameters of the babies who are born at different ages of gestation are calculated and then they are plotted on a graph, and then we will have the respective data. In the postnatal chart, so first let's see the intrauterine charts. So the first chart was done by Lubchenco, and then subsequently many people have done the growth charts from the years of around 1966 to 2001. In 2001, Kramer's charts were released. So you can see the different types of intrauterine charts. So they predict the anthropometric data of preterm infants which are born at different gestational ages, and then they have given the charts to us. So what are the drawbacks of these charts? The sample size could not be more for this chart, and they were not gender specific charts. And the another drawback of this chart is they used last menstrual period for gestational age assessment rather than the first trimester ultrasound. And these were all cross-sectional data, not a prospective data. So because of the small sample size, these charts were later became less popular, and subsequently many other people have done investigations to give us many different types of charts. So these were the Lubchenco charts. Here you can see this is an intrauterine growth chart. The data was collected from 4,700 newborns who were born between 26 to 42 weeks of gestational age. At the birth, the baby's anthropometry is plotted on this graph. So Lubchenco was the first person who was able to define the small for gestational age, appropriate for gestational age, and large for gestational age babies. There was only one flaw with this chart, which was the data was collected from only one country, and that country was at high altitude. So it is not applicable to different ethnicity of the populations and different geographical areas. So that was about the intrauterine charts. Next, the postnatal growth charts are longitudinal charts. They take the anthropometry of the baby who was born and continue it. So they also account for the postnatal weight loss, and they don't define a healthy preterm, because a healthy preterm who is intrauterine will gain even more weight than a baby who is born and is facing with all these morbidities. So the examples for postnatal growth charts are Dancis chart, Schaeffer, Wright, Berry, and Ehrenkranz charts. Ehrenkranz took data from 12 centers in United States of America of around 1660 infants weighing between 501 to 1500 grams of birth weight. So in these postnatal growth charts, we will understand the weight loss of the baby after birth due to loss of the extracellular fluid volume and the time to regain the birth weight. But these charts were also of small sample size and the population was from a single country. And there was another drawback of this chart is it had a single line trajectory like this. So coming to the next fetal infant growth charts. This is a combination of cross-sectional data of intrauterine growth charts and the postnatal growth charts. They combined both the methods and posted a cross-sectional data at birth and then followed it up with the longitudinal data after the birth of the baby. So through these growth charts, we can assess whether the preterm baby achieves the catch-up growth at the right time. Examples of these charts were Babson and Benda charts, followed by the Fenton's charts. The Fenton's charts was done in 2003. They studied between the gestational ages of 22 to 50 weeks. It was a large study. They took a large number of population of infants under consideration, but it was not a gender-specific chart. So Fenton themselves revised the chart in 2013 with the data collected from 4 million infants, large population of infants gathered from 6 different countries: Germany, Italy, United States, Australia, Scotland, and Canada. The advantages of the Fenton's revised charts are they give the size per gestational age, and there are gender-specific charts like the ones I have showed you before. And these charts are smoothened, the curves are smoothened by 50 weeks post-menstrual age, and subsequently, once the baby reaches 50 weeks, the growth can be plotted on the WHO MGRS charts. So we can plot the growth of the baby in between the weeks also in the Fenton's charts, and the curves were smoothened according to WHO charts at 50 weeks of PMA. The disadvantage of the Fenton's chart is it's a growth reference chart, not a growth standard chart, and they did not mention anything about the postnatal weight loss, and the methodology that was used was not according to the standards. So this is the Fenton's chart. There are gender-specific charts for boys and girls. These charts we regularly follow in our unit to plot the growth of any preterm baby till term gestation, and then we later on move on to the WHO charts. So here if you can see, so every week is mentioned on the x-axis in the form of like 22 weeks, this middle line 23, 24 like that till from 22 weeks to 50 weeks, and in between days also we can plot in this chart. And on the y-axis we can see the parameters for the weight at the lower end. This is like 0.5 means 0.5 kilograms, that is 500 grams, then 1000 grams, 1500 grams. And as we go higher, there are the parameters for the head circumference and the length. So everything can be plotted on the same chart, and the centiles range is also given like 3rd centile, 10th centile, 50th centile, 90th and 97th percentile. So because they are gender specific, they can be used separately for boys and girls. So coming to the standard growth charts, till now we have seen the descriptive growth charts. Now we will see the prescriptive growth charts, which tell us how the baby should be normally growing. So the WHO MGRS team, over a span of 6 years, conducted studies from 6 countries of different continents. They included both the developing and developed countries because the genetic potential and the growth of the babies in each group will be different, and they have considered only the full-term breastfed infants. They have not taken babies who are born to mothers with any risk factors, just because to tell us prescribe which is the normal growth of a healthy term baby. So those babies were followed with longitudinal anthropometry till 24 months, and then cross-sectional data was collected between 2 years to 5 years. So these are the prescriptive growth charts. They excluded more than 2 standard deviations above the median to exclude the babies with overweight and obesity. So this was a large study, but the only flaw in this growth chart was it was not intended for preterm. It can be used only for the term babies after 40 weeks of gestation. So one thing we can do is for premature babies, we can use the Fenton charts, and once the baby reaches term, we can follow the WHO MGRS chart. Then the intergrowth group of consortium released the intergrowth 21st chart collected by data from 8 countries, that is India, China, Italy, Oman, Brazil, Kenya, UK, and USA. So they prescribed three types of charts, that is the fetal growth longitudinal study, preterm postnatal follow-up study, and newborn cross-sectional study. Among the fetal growth longitudinal study, the gestational age was determined by using both the last menstrual period as well as the first trimester ultrasound, and standard fetal growth curves were designed based on the occipitofrontal diameter, head and abdominal circumference of the baby, biparietal diameter, and the femur length. Then subsequently of all these infants, around 201 infants were born preterm, and then they followed up those preterm infants from 26 weeks to 37 weeks, and these charts can be used till 64 weeks also, after which WHO MGRS charts can be used. Coming to the newborn cross-sectional study, gender-specific percentiles were considered based on the weight and the head circumference from 20,486 babies born between 33 to 42 weeks. So the advantages of this chart is they have considered a huge population of infants, and this is a multi-ethnic, multi-country, and gender-specific type of charts, and it is also a prospective chart. They followed a uniform research method and protocol in that the same methodology and monitoring and plotting of anthropometry will be followed by all the staff who are taking care of the babies across all the countries. And they also used the identical equipment for the measuring the anthropometrical data, and the training will be given for this staff, and there will be a overall centralized monitoring of the these data through a centralized office. So these are the intergrowth 21st charts for both the boys as well as girls. So the only drawback of this intergrowth 21st chart is, if you can observe, the preterm follow-up study included a small number of infants, only 201 infants, and there is not much data for babies who are born less than 33 weeks of gestation. That is the drawback of this study. So till now we have seen the growth reference chart and growth standard charts. So now let us see what is the normal growth. Growth is the increase in the size or mass of a tissue, which occurs either by multiplication of cells or increase in the size of the cells. So how we will know whether the postnatal growth is appropriate or not. So we should monitor the weights daily for preterm babies in NICU, and we should calculate the cumulative weight gain every week. So that will be done by the this day's weight gain compared to the difference between this day's weight gain and the weight which was taken last week on the same day, and that is divided, average weight is taken, and that is divided by the 7 days. So that will give us the grams per kg per day. That is the cumulative weight gain over the 1 week, and the weight gain per day should be ideally 15 to 20 grams per kg per day until 36 weeks of postmenstrual age, and later on 20 to 35 grams per day from 36 weeks until 2 months. So the length and head circumference should be monitored weekly, and ideally it should be 0.7 to 1 centimeter per week. So this is very important for any baby who stays for long in the NICU, that is ideally any premature baby. So now we should know why the growth faltering occurs. So let's see what is extrauterine growth restriction. Extrauterine growth restriction is a kind of nutritional emergency in preterm and critically ill term infants where they don't catch up on the anthropometric centiles. So it is defined as the weight less than 2 standard deviations or the less than 10th centiles when it is measured at 36 to 40 weeks or at discharge. So many people believe that it is difficult to match the fetal growth in the babies postnatally. This is because of the many morbidities they face. But if we follow according to the standard protocols and have some unit-specific protocols, then it is not impossible to achieve the intrauterine growth rates. According to many studies, the babies after the initial postnatal weight loss, the babies grow at a range of minus 0.8 Z scores and follow the trajectory until the time of discharge. So coming to the common causes of EUGR. So the premature babies who born early by skipping the last trimester, they miss the stages of nutritional accretion and the rapid growth which occurs when the baby is inside the womb. And this is coupled with the poor nutrition which occurs during the initial phases of life and repeated feed stopping and for feed intolerance during the critical phases of illness. And then illnesses like sepsis, PDA, feed intolerance, NEC, BPD contribute significantly to the growth faltering in the babies. So when we are seeing EUGR, we should take the other parameters also into consideration. EUHGR is the extrauterine restriction of the head growth, which is the head circumference less than 2 standard deviations below the age-specific Z scores. Post-discharge head growth is associated with a better cognitive outcome. So coming to the incidence of EUGR, so the EUGR is a very common problem in VLBW babies. That is 97% of all the very low birth weight infants and 99% of all the ELBW infants face the problem of extrauterine growth restriction. And according to this chart, if you see the incidence of EUGR is inversely proportional to the gestational age at which the baby is born. So if you can see the growth percentiles of the baby, this baby is born at around 24 and a half weeks of gestation. This baby is born at 26 and a half, and this is at 20. So 2 weeks of difference is there between these three babies. So the higher gestational age baby, like if you can see that baby is growing well and is almost close near to the 10th percentile at the time of discharge when compared to the other babies of the lower gestational ages who are way beyond the 10th percentile. So after considering the survival chances of the babies, that is 54% of EUGR is seen in babies who are born around 500 to 750 grams, because the mortality is also higher in babies who are born at lesser weights. This study is according to the Lemons et al. Study published in the NICHT 2000. So coming to the definition of EUGR, the one which we have already seen, it is not an ideal definition because the EUGR definition should also correlate with the neurodevelopmental outcome, and it should also consider the weight, head circumference, length, and early postnatal weight loss, and also take into consideration the genetic potential of the baby. So this is the common definition which is given: the weight less than the 10th centile or -2 standard deviations at 36 to 40 weeks. But ideally, it should also take into postnatal weight loss and other parameters like head circumference into consideration. So, and the relation to neurodevelopmental outcome should also be studied. So, understanding the developmental origins of health and disease. So, whenever we are targeting the ideal nutrition for a baby, we should also consider that, and precaution should be taken that we should not overfeed the baby, give many nutrients to the baby, because in IUGR and small for gestational age babies, when they grow up, they are at high risk of developing the metabolic syndrome, they may develop the obesity, diabetes mellitus, hypertension in the early years of life. This occurs because of the genetic programming. So if you can see this study by Rocho et al., the physiological adjustment to postnatal trajectories in healthy preterm infants. So after the initial postnatal weight loss, the baby should grow at -0.8 standard deviation below the expected growth percentile, and then be able to reach the appropriate centile by the term gestation. That is the ideal weight gain expected. If you are providing nutrition in the form of excessive fats to the baby, like here you can see when the baby is born, this yellow color is the fat percentage of the baby, which is around 3%. So if the more of nutrition, like overnutrition, is being provided for the baby, their fat percentage of the body, like when compared to the lean muscle mass, increases when compared to the fat mass. So this is the reason and the cause for the metabolic syndrome in IUGR babies in their future. Now let us see the classification of IUGR. So according to the weight for age Z scores, mild IUGR is defined as a decline of 0.8 to 1.2 standard deviations below the median. Moderate is more than 1.2 to 2 standard deviations, and it is severe EUGR if it is more than 2 standard deviations. According to the weight gain velocity, if it is less than 75% of the expected gain for age, it is mild. Less than 50% of expected gain is moderate, and severe EUGR if the baby is growing at less than 25% of the expected speed. So the same applies to the length for age scores and the length gain velocity. The days to regain birth weight. Ideally, the preterm, any premature baby should regain the birth weight by 10 to 14 days of age. If the baby is taking longer, like 15 to 18 days, it is mild EUGR, 90 to 21 days is moderate EUGR, and more than 21 days is severe EUGR. Let us see briefly the etiology of extrauterine growth restriction. It can be divided into these factors, that is antenatal factors, postnatal, increased energy expenditure, metabolic demand, surgical causes, and factors related to malabsorption. Among the antenatal causes, the several maternal conditions like maternal anemia, pregnancy-induced hypertension, neuroplacental insufficiency, diabetes, maternal infection, chorea amnionitis, lack of antenatal steroids, they all contribute to the overall health and well-being of the baby. Postnatally, these are the causes. The more extreme premature the baby, delayed transition at birth, delayed cry, perinatal asphyxia, need for ventilatory support, male gender, sepsis in the baby, any culture positive sepsis, and feed intolerance. These are all the factors which contribute to postnatal growth faltering. Increased energy expenditure occurs when the baby is breathing very fast, like in the case of respiratory distress syndrome, having sepsis, metabolic acidosis, and bronchopulmonary dysplasia. Metabolic conditions leading to EUGR are anemia, hyponatremia, hypothermia, micronutrient deficiency. These are the common causes. Surgical causes are any grade of NEC. Any surgical causes like malrotation, intestinal atresia contribute to EUGR. And malabsorption syndromes, so these also contribute to a significant interruption of the feeds in many babies, like cow's milk protein related intolerance and lactose intolerance. So the etiology can be divided into the baby-related factors and iatrogenic factors. This is the most important area where we should try to avoid these iatrogenic factors. Some of the baby-related factors like preterm birth cannot be avoided by us. It can be postponed in some conditions, but we should try to, like in the case of prematurity, if the mother has obviously gone into the labor, then the in utero transport should be arranged and the delivery can be planned in such a way that it happens where there is a nearby availability of a tertiary care level NIC, so that initial golden hour management can be taken care appropriately. And other baby related factors are IUGR babies, SGA babies, cold stress at the time of birth contributes a lot to the increased mortality as well as affecting subsequent weight gain. Severe RDS, this can be treated by early delivery room CPAP and provided surfactant whenever needed. So BPD, NEC, all these conditions should be identified and recognized early and treated appropriately. PDA, any baby who is on respiratory support having increased work of breathing and having bounding pulses, precordial activity, wide pulse pressure, we should suspect the PDA and diagnose it by doing the bedside ultrasound or getting the echo done by the cardiologist and treating the PDA appropriately. In this way, we can avoid the PDA related complications like feed intolerance, shock, and IVH. Post surgery is a common cause, like post any cardiac surgery or intestinal surgery is very common complication for subsequent EUGR and malabsorption syndromes, as we discussed. Post NEC, post surgery, short bowel syndrome also leads to the malabsorption and leads to the EUGR. Chronic liver disease, so TPN related cholestasis should be avoided and any intrauterine infections should be identified and treated promptly. So iatrogenic, whenever we are anticipating any preterm baby, preparing for the same, like adequately arranging the warmers and incubators and heated humidified gases for resuscitation, and treating early RDS, PDA, and BPD, and early aggressive provision of nutrition to the babies helps a lot. And interruption of feed should be minimized. Unit protocol should be followed, and fortification should be there. And we should avoid TPN related cholestasis, sepsis, and anemia. So these are all the common factors which contribute to the poor weight gain and EUGR. So we will see how each one needs to be taken care of in our subsequent slides. So we have seen the risk factors till now. So among them, Like by now you would have realized that some are modifiable risk factors where we can act upon, and some are non-modifiable risk factors. Let us see what are modifiable risk factors. So the energy and protein requirements, early provision of TPN and early amino acids, and minimal enteral nutrition and hiking feeds, these are the modifiable risk factors. So where we should start the minimal enteral nutrition, it will not increase the incidence of NEC, and we should have a unit specific protocol where the feeding is increased in a upgraded in a stepwise fashion, like according to the SIFT protocol, where they have compared like 18 ml per kg per day versus 30 ml per kg per day. There was no increased incidence of NEC in the babies who were given feeds increments of up to 30 ml per kg per day. So this can be followed in any unit where they are caring more for the preterm babies. And we should avoid overcautious interruption of feeds and increase the feed volume according to the weight. So this should be discussed in the daily rounds, and fortification of milk should be done whenever possible. So the non-modifiable risk factors are genetic reprogramming, which occurs in some babies like EUGR babies. So where there will be the hypermethylation of the imprinting center gene. So this can be both due to these nutritional factors as well as environmental factors. And the babies also have a circulating higher bile acid levels, which leads to the TPN related cholestasis. So some of these genetic factors then become non-modifiable. If we identify and treat the modifiable factors, then we can also avoid the non-modifiable factors. So now let us see the stepwise approach to the EUGR. So I will begin with the one by one aspect, with the nutritional aspect. So whenever any premature baby is born, so we should first immediately counsel the mother. Antenatally itself, we should provide a lactation counseling to her and educate the mother about the importance of providing her own mother's milk to the preterm baby, because the direct breastfeeding cannot be provided immediately. We should encourage her to take an appropriate diet and frequently pump, because pumping is one of the most important prescription to be given to a mother whose baby is in NICU. And then support the mother. There should be like zero separation. The mother should be always allowed in the NICU and have access to her baby, and she should be like provided access to the breast pump, and she should be shown the appropriate way and the duration for how much time she should use the pump. In the initial phases of lactation, manual pumping is better than the electrical pumps. Then later on, once the mother starts getting the letdown of the milk, she can pump using the electrical breast pump. Nutrition aspect should be taken care of, and she should be explained in a detailed manner, like regarding the frequency of the pump, importance of pumping feeds in the night, and supporting her baby with the adequate provision of her own milk as well as KMC and non-nutritive sucking. So our nurses should be trained in this manner, and they are the main motivators and supporters for these mothers who come every day to see the babies, because the nurses will always be bedside and they can help the mothers with the milk expression and train them and motivate them. So once these mothers, they start pumping exclusively and start doing KMC, they themselves gain good knowledge, and they themselves will start ask us, when will you give our baby to KMC, to kangaroo mother care? Because in our unit, they get motivated by seeing the other parents, and in that way they form the groups where they'll have the positive reinforcement and do the exclusive breastfeeding for their babies. So early pumping and provision of mother's own milk successfully transitions the baby to direct breastfeeding also at the time of discharge. So this is the main concept of preventing EUGR in neonates in the NICU, nursing training, and encouraging exclusive provision of mother's own milk. So coming to the second aspect, the nutrition. So early aggressive nutrition should be provided to the baby. Supposing like we expect the delivery of a extreme preterm baby. So the initial resuscitation golden hour management should be taken care of appropriately, like providing the appropriate temperature care, like receiving the baby is with, maintaining the delivery room temperature more than 26 degrees centigrade, receiving the baby in a polyethylene wrap cap, and resuscitating the baby using heated humidified oxygen, and providing early delivery room CPAP, and taking care of the baby in the incubator with appropriate humidity. Monitoring of admission temperature is very important to prevent the hypothermia in the babies who are born. And all these procedures like placement of umbilical lines and giving the surfactant, everything can be done while the baby is still under the polyethylene wrap before the baby can be transported to the incubator. And then respiratory appropriate management, like delivery room CPAP, treating RDS aggressively, early detection of PDA, prevention of sepsis by taking appropriate hand hygiene precautions, and having the 1:1 nursing for extremely preterm babies. This is very important in preventing the sepsis in the babies. Early identification of IVH and PDA by doing this bedside point of care ultrasound also helps in preventing the morbidities in the babies. So if we can try to achieve to prevent the sepsis in any baby, then that will reduce the duration of the total parental nutrition days, and early mother's own milk and kangaroo mother care will help the baby to reach the full feeds early, and the baby will also tolerate the mother's own milk early when compared to the donor milk or formula milk. Formula milk should never be used for any premature baby. If mother's own milk is not available, then at least pasteurized donor human milk should be provided to the babies by establishing more number of human milk banks where the milk can be pasteurized, and safely this PDHM can be provided to the babies. And early aggressive nutrition on the immediately after birth, as soon as after birth, the total parental nutrition should be prepared, and early parental nutrition, starting with an amino acid in the initial days of 2 grams per kg per day, and then increasing as tolerated to up to 4 grams per kg per day, because these preterm infants every day they lose 1.5 to 2 grams per kg of protein because of the catabolism, and they also have limited stores of protein in their body. And if the baby who is not provided with in the first 3 days with any amino acid will lose up to 10% of the protein from their body. So early protein provision by total parental nutrition through any umbilical line or peripherally inserted catheter is very important to prevent these metabolic crises in the baby. And the GIR should be also adequately targeted, starting from 4 mg per kg per minute. It can be increased up to 8 mg per kg per minute, and lipids and other metabolites can be elemental trace elements need to be given only in the case of prolonged parental nutrition, and the enteral feed should be tried to establish as early as possible. If there are no Doppler abnormalities, preterm babies can be started on minimal enteral nutrition on the day one itself. This has been shown not to increase the incidence of NEC, and also helps in establishing the full enteral feeds for the baby. So if babies are born with Doppler changes, like we have seen in our second case, then we start feeds generally after first 24 hours of life. So this is the early nutrition, which helps in preventing the EUGR. Then the third aspect is increasing the nutrition. So how we will increase? So we will start with 10 to 20 ml per kg per day. In stable, very low birth weight babies, early full enteral nutrition can be started. But in very low birth weight babies, like less than 1200 grams, these babies need to be started on minimal feeds, and then the feed needs to be increased as per the unit feeding protocol. Parental nutrition is given for any baby who is not expected to reach the full enteral feeds by at least 3 days of life. So we will initiate on day of life 1 itself, and then we will increase according to first 1 day we are increasing 20 ml per kg per day, then we are increasing every day by 30 ml per kg per day. And there should be sufficient monitoring of this baby. So what all things we need to monitor for a baby on OG feeds? We should see for the abdominal girth, and then we should monitor for any aspirates. There should be no routine pre-feed aspiration, that is not at all required now. And we should monitor the abdominal consistency, palpate the abdomen whether it is soft or are there any visible or palpable bowel loops. All these things should be monitored every day, and should be monitored closely for any feed intolerance. So fortification should be added. The NNF CPG guidelines recommends that fortification can be given for any baby who is born below a weight of 1800 grams, and the fortification can be started anytime the baby tolerates 50 to 80 ml per kg per day of mother's own milk. So there are different kinds of fortifiers, like the human milk fortifier, which is derived from the cow's milk, and the other fortifier is maternal milk fortifier. Initially, the human milk fortifier can be tried, and if the baby is tolerating well, the HMF can be continued. So, one sachet of HMF need to be added in 25 ml of expressed mother's milk, and the baby should be monitored regularly. So feeding should not be stopped at the drop of a hat, like if the baby had some aspirate, like milk aspirate, but the baby's abdomen is soft, girth has not increased by more than 2 centimeters, and there are no bilious aspirates, and there are no local signs on the abdomen, like visible or palpable bowel loops, tender abdomen, and there is no discoloration of the abdominal wall, baby is passing stool normally, then there is no need to stop the feed for minimal aspirates which come through the orogastric tube. So feeds can be continued at the same level, and then keep monitoring the baby with the help of X-rays, and to look for any radiological evidence of NEC, and ultrasounds can also be done to look for the NEC changes. So with proper early aggressive nutrition, early thermal care, early respiratory support, prevention of sepsis, the time to regain birth weight will be ideal in most of these babies. So fortification, as we already discussed, can be initiated in babies who are tolerating 50 to 80 ml per kg per day of feeds. And there are 3 different types of fortification. What many units follow is the standard fortification, in which for every 25 ml of mother's milk, 1 packet of HMF human milk fortifier is added. So there are other 2 different types of fortification, like adjustable fortification and targeted fortification. In the adjustable fortification, the amount of fortifier that needs to be added is determined on the basis of blood urea nitrogen values of the baby. So ideally it should be more than 16 value. If it is less, if the blood urea nitrogen value is less, then the protein that needs to be added is increased in the mother's milk. Targeted fortification is done by checking the protein status of the expressed mother's milk. This is possible with only specialized equipment, and is done in only few centers. So just for our knowledge sake, we should know that these are the different types of fortification that are available. And for babies who don't tolerate the cow's milk based fortifier, there is a maternal milk fortifier, which is of a little higher cost, but it is easier for the baby to tolerate. So the next one is avoid frequent disruption of feeds, as we have discussed, unless you see any warning signs, which I have mentioned, and avoid measuring the gastric residuals frequently. To do all this, by now you have understood that a team approach is always necessary. So we should, like, in addition to the neonatologist taking care of the NICU, we need a dedicated nursing staff who will understand the importance of this. So once we educate them regarding the importance of the mother's own milk and the other care procedures needed for the preterm baby, they will follow it very sincerely. And we also need a lactation counselor to counsel the mother antenatally itself, as well as postnatally, also support the mother to express the milk, and a dietitian to explain the diet and other health related practices that need to be followed by the mother, need to take any galactocoax if necessary. And the human milk banks are the way forward. They help in providing exclusive mother's milk, like pasteurized donor milk to the needed babies. And we need a personnel for that also, to manage the human milk bank and send those pasteurized milk cultures. We need staff who are trained in that manner, and there is always scope for improvement. So our PG students and the fellowship students who are working in the neonatal ICUs can take the quality improvement projects, so to see where we are lacking and where there is ample scope for improvement. So I will tell you the one sample quality improvement project which can be done. So always the mother's milk, NICU should be mother's milk protein. So we should always try to be breastfeeding friendly in a way that we will educate our mothers regarding her frequency and expression of milk, as well as the diet and galactobox, early expression, frequent expression, night expression of milk, and educate her how to store the milk. And there should be ample space where she can express the milk in privacy in the human milk bank. And there should be facilities for appropriate storage and handling and pasteurization of the milk, and distribution of this milk, and discarding the milk if the cultures come positive, and encouraging the mother to do the kangaroo mother care and non-nutritive sucking at the same time. And they also, like a motivated group of mothers, they benefit each other, like they will share their knowledge, and they will help in decreasing the incidence of EUGR. So this is a quality sample fishbone analysis of a QI project. So in this we will try to understand the problem in different parameters, like according to the person wise, in respect to the mother or our nursing staff or doctors, is there is sufficient knowledge uh, about the different ways to prevent EUGR. And if they are having knowledge, are they implementing it into practice? Are they motivating each other? And are they sustaining that practice? So this part can be taken into consideration. Then regarding the if a mother has any knowledge about expression of the milk, but there should be an ideal place to do that. So there should not be separation from her baby. That will lead to again maternal anxiety and affect the milk supply. So maternal access to NICU should not be prohibited, and she should be allowed anytime to come into NICU and express milk at her own leisure, and adequate equipment should be available. So and KMC facilities should be available. So if the facilities are not there, then the whatever knowledge we are having will not be culminated into the practice. So that is, the first one is person, then the second one is place, and we should have a standard policy which is followed by each and every member of the team. If one says one thing and the other person says other thing, the parents will get confused, and that will lead to fallout of the practice. So a standard feeding policy and standard TPN policy should be followed by each and every staff in the NICU. That leads to decrease in these incidences of feed tolerance, and fortification also, as we discussed, according to policy. And then there should be appropriate equipment for the storage and administration of the mother's milk. So this is one type of analysis. We can see the time to initiate the TPN and the time to initiate the mother's milk. So that is one analysis that we can take up in our NICUs, where we can see if we improve these any of these practices, whether the incidence of the EUGR is coming down or not. So in this study, so they have done these methods as a QI protocol, and did the PDSA cycles, Plan, Do, Study, Act cycles. So you can see by every year, like in the 2008 to 2009, the postnatal growth failure rate was around 80%. So once the QI project was initiated, then that rate has gradually come down, and over the period of years, that lead to sustenance below the goal. So that means once the goal is achieved, then again it should not go back. So this needs what regular classes and teaching for the nurses, as well as the regular monitoring. So that will lead to the sustenance of these practices. So this is what is shown in this chart and these two charts, which leads to the drastic fall after starting the QI initiative. So the drastic fall in the EUGR rates, and people who don't believe that babies can achieve the intrauterine growth rates will be proven wrong, like if we follow according to the standard practices. So a few words about the evidence. So standardized feeding regimen decreases the rate of necrotizing enterocolitis and sepsis in the babies. Early aggressive nutrition helps in the long-term growth and neurodevelopment. And minimal enteral nutrition, early versus late, that is less than 48 hours to more than 72 hours of initiation of enteral feed, significantly decreases the time required to reach full feeds, time to regain birth weight, and also decreases the duration of TPN. The donor human milk also decreases the incidence of NEC, thereby highlighting the importance of pasteurized donor human milk for premature babies. Fortification also helps in better weight gain, length, and head circumference. So these are all evidence-based practices which you can research or read up in your free time. So overall, the prevention of EUGR is a holistic approach. So if you plot the growth of a baby on a growth chart, so the first one is the birth weight. So what are the actions which need to be taken? On the x-axis, you can see the days of life. So this is the day 0, day at birth, and then 5 days, 10 days, like that. So at each point of time, there are certain specific measures that need to be taken. So like when the baby is born, so what are all the measures that need to be taken at this time? So golden hour management, monitoring the temperature, maintaining the admission temperature of the baby by using the polyethylene wraps, caps, and using the heated humidified gases for resuscitation using humidifiers, thereby decreasing the insensible water loss and decreasing the intracellular volume loss, providing early amino acid, that is early TPN, advance the TPN as per your unit protocol, and provision of early minimal enteral nutrition. So as soon as the baby now has will have some drop of weight. So baby will reach the nadir weight and will reach, ideally the return to birth weight should be by ideally 10 to 14 days. So if we can achieve this, then we have come halfway. So then how to make the baby tolerate the feeds better? By providing the mother's own milk. So that we discussed in detail, how to motivate the mothers and all those things, and encouraging them to do the KMC sincerely, fortification, monitoring for feed intolerance, and preventing the morbidities, mainly sepsis, and treating the other comorbidities like RDS, PDA appropriately. So this is during the course of the baby in the NICU. So then once the baby weans out of respiratory support and becomes a just normal feeder and grower, then at that time the baby will not again end up having so many feed intolerances. So once the baby gets discharged, so our role does not end with the discharge of the baby. So if the baby needs to achieve a catch-up growth, there should be a proper plan for following the baby after discharge also. This is called as post-discharge nutrition and education of the mothers at the time of discharge regarding the thermoregulation, maintaining the body temperature of the baby. There should not be any core to peripheral temperature difference, and the baby should be appropriately swaddled and need to be fed at in regular intervals. Spoon feeds need to be taught for the mother, and the provision of the supplements time to time, like iron and calcium if needed, human milk fortifier. Fortification can be continued even after the discharge of the baby also, until the weight of 2 kgs. And providing the non-nutritive sucking from the earlier NICU days itself help in establishing the mother on direct breastfeeds as soon as the baby reaches a weight of 1.8 to 2 kilos. And regular growth monitoring in the follow-up, regular immunizations. So all these post-discharge measures also help in improving the catch-up growth rates of these babies. So like once, so this is the end of the slide, but I once want to go back to our first case. So where we can see like what are all the improvements that need to be done in the case of this baby. So I will tell in a stepwise manner. First and foremost is this baby was born as an appropriate for gestational age baby with a birth centile of 780 grams. So the thing here before the delivery is in utero transfer of the mother and delivery in a tertiary care center. Try to complete the antenatal steroid course and wait for the at least 24 hours after the second dose for decreasing the morbidities in the baby. And then golden hour management, maintaining the appropriate admission temperature, maintaining the humidity of the baby, and maximum try to avoid the invasive ventilation, and try to maintain the baby of non-invasive ventilation CPAP itself. Here the volume was started at 60 ml per kg per day because of the fear of opening the PDA. So if there is an incubator care available and the humidity can be taken care of, then the fluid restriction may be attempted, but fluid restriction has not been shown to be of that much significant in the treatment of the PDA. Early identification of the PDA and treatment is even more important than fluid restriction. And we should try to avoid this non-invasive ventilation as much as possible and provide early nutrition. So if the baby has not been fed in the initial 2 days and the temperature and humidity has not been taken care of, the baby already lost 10% of the body weight. So then initiation of feeds. We should not keep NPO at the drop of a hat, and we should always monitor for warning symptoms of NEC. Then only we should keep the NPO. Repeated stoppage of feeds also increases the rates of sepsis in a premature baby. So then once sepsis sets in, then again the feed intolerance will become prolonged, the respiratory support become prolonged, and then ultimately the baby ended PPD. Early monitoring for this diarrheal losses, any water loss from the body, and early identification of anemia and hyponatremia. If the baby is not showing any weight gain over the few consecutive days and is having tachycardia, so regular monitoring of the lab parameters, and if not gaining weight, checking the sodium needs to be done on time. And feed intolerance should be avoided with exclusive mothers on milk, and prolonged TPN should be avoided. That was the case in this baby, which led to the cholestatic jaundice. So repeated blood transfusions can lead to the CMV infection, at risk of CMV infection for the baby. So that ended up having a prolonged NICU course for this baby, and that ultimately ended up for the baby going into the EUGR. So this should be avoided. So the one we have seen in the case 3, where the baby was completely steroid covered, baby was never ventilated, baby was on CPAP, established on feeds, and came to full feeds by the end of 1 week of life. That baby did not go into the EUGR. I hope that you can understand all the causes of and management of EUGR through this session. Thank you all for joining. Bye.